Thank you very much, PK and Dr. Arabi. Well, this is an interesting time since in the prevention field, the role of imaging is coming very rapidly, and obviously it's a question of economics. My talk today is going to be entitled CT MRI and CRP calcium score in the risk stratified pyramid. Actually, it's almost similar to what was presented by Dr. Brownwell with the same figures. This is my pyramid. And this is... That's a two-dimensional triangle. All right. This is an intermediate risk asymptomatic patient who may have one or two risk factors from Framingham, and this is the high risk asymptomatic patient who would like to look at whether he's developing subclinical atherosclerotic disease. So this is all primary prevention in a way, which is, just give me a second to switch this off. Thank you. So we are talking about below this line, and these are the two groups that I'm going to be concentrating on. Now, what is an intermediate risk asymptomatic patient? If you go to Framingham, really it's the group between 5 and 20% events, heart events of coronary disease over a 10-year period. And if you go backwards, how do you get this risk looking at the score? As you know, these risk factors, they give you a score. Well, basically, if you age over 54 in a single risk factor puts you into the category of an intermediate risk score. And that is, we have to be very careful because most of us sitting here might be in that range. Therefore, we are not going to start doing imaging on everybody to see what is going on. I'm just presenting this just to start as an introduction. I think this is critical. This comes from the Narens study, where if you have a prediction for Framingham from 5 to 20% events over a period of 10 years, this is the intermediate risk, which is about 40% of the population. The question is, if you now test the patient with all the stress tests that we do and even angiography, you find that actually a large number of these patients are lower risk or higher risk than you might have predicted. This has made the thought that maybe this is the group of patients we have to test. I tend to agree partially, but I wouldn't use imaging in the way we are going to describe today, because this is a very significant population. It's 40% of the population. What I would do is to use a marker like CRP, and we might consider calcium scoring. And this is what I'm going to present in the next 2 or 3 slides. This is the data from the Women's Heart Study, Paul Ritker's data, and I have actually had 4 other studies showing the same thing. This is the intermediate risk of patients at Framingham, from 5 to at least 20%. If you now have a CRP which is more than 3, you can see how you can make patients from the intermediate risk to go towards a higher risk. So a reasonable marker. Now, if you look now at calcium score, and this is the intermediate risk patients from 5% to 20% over a 10-year period. If the calcium score is below 80, no problem. You are really almost in the low risk. But if the calcium score is above 80, you really jump into a high risk very rapidly, regardless of the score of Framingham. And what this is saying is the calcium score is very good to really tell you where you are in the intermediate risk with Framingham, as well as the CRP. And this is other data from the calcium scoring, where from Greenland, just published 3 weeks ago, where you can have the Framingham score intermediate here, from 10 to 20%, and now you have a calcium score of more than 300, and over a 7-year period, you are already moving towards a high-risk patient. So my conclusion here, in talking about the intermediate group of patients, between 5 and 20% per year, it seems to me that this is a group that we may do more than the conventional risk factor profile of Framingham. We might add CRP, maybe we might add calcium score, and we could tell whether the patient is in the high-risk category or not, which we might have missed. So this is the first point I want to make. Now I'm going to move into the high-risk population. The high-risk population is a group of people who have more than 20% risk of a coronary event over a 10-year period following Framingham. And these patients have 2 or 3 or 4 risk factors. And the question is, are they developing the disease? We are not interested in markers so much. We are interested in seeing the anatomy, whether they are developing disease or not. And this is where we are going now to at least present to you an update on the technology that is evolving to assess whether or not a high-risk patient has coronary disease. First of all, we know, I don't like the term vulnerable plaque, and I'm not going to discuss it any longer. We call high-risk plaque, high-risk blood, and burden of disease to start with. Regardless of what you define here, we are talking about a systemic disease. And in fact, we just look at the CAPRI registry and the TAS registry in Europe and the United States. And it's very interesting how the disease advances systemically with time. In fact, today, any patient over age of 55 that presents with one of the 3 systems affected, there's a 25% chance that has a manifestation of a second of the 3 systems. And actually about a 7% chance of having the 3 regions involved. The disease really is systemic, and I will show you this to you with imaging. Very rarely you just see coronary disease. In other words, this is a systemic disease. And if you have claudication, you are not going to die of claudication, but you will die of a heart attack, and has the same risk factor profile in itself that if you have angina. So the whole issue here is we have to really take into account the whole arterial system when we talk about risk of a particular patient. Now, let me move into the second issue of these imaging technologies. I really feel very compulsive to say the following. We cannot find the vulnerable plaque. There are meetings and meetings and meetings. Let's find the vulnerable plaque. Forget it. This is my view. There are too many. And once you go with imaging, you see them. And which one is going to explode? Any patient with a coronary event has already 12 plaques that you would call vulnerable, if you look at the coronary system. A patient with claudication, I will show you this in a moment. So the issue of let's go to find the vulnerable plaque, to me, is a complete dream of a poet. Because prospectively, you know, at autopsy you can. That plaque exploded, this was vulnerable. This is all retrospective, but prospectively, good luck. If with imaging technology you will tell me which plaque is going to make it bad in the future. Anyway, I have said enough about this. There are too many. And actually, this slide was going to point out this. Let's move into the next. Why I like the term high-risk plaque and why I don't like the term vulnerable plaque? Because the term vulnerable plaque implies fat. Fat is there and the plaque breaks. The term high-risk plaque is telling you that 50% of the cardiovascular events, there is no plaque rupture. Therefore, that plaque that is very stenotic and very fibrotic and is in your carotid artery and doesn't have plaque will lead to a stroke, and you will miss the plaque saying is not a vulnerable plaque. It is a vulnerable plaque, but in a different sense that fat is a very fibrotic. Claudication, there is no literature at all that an occlusion in the leg relates to plaque rupture with a high content of fat. All the occlusions in the leg that you see in the literature are very fibrotic plaques that a clot takes place on top of that plaque. I want to make this point very clear that if we talk about vulnerable plaque, it's fine to me, but then be sure that we are not talking only about fat and plaque rupture. And I'm not going to be discussing this in detail, but this is all the work we have done in the last 3 or 4 years. And I just like to summarize by telling that from the coronary plaques, 2/3 are plaque ruptures of a lipid pool. We believe that 1/3 is a very stenotic plaque, very fibrotic, and is a hypercoagulable state. We find very high tissue factor activity in blood in these patients, which I'm not going to discuss now. In the carotid arteries in green means most of the plaques actually that lead to a stroke are very stenotic and very fibrotic. And this is actually a dissection. Is the ejection of blood during systole impacts into a plaque that vibrates because it's narrow. And then you have there a dissection. very different than a plaque rupture that is spontaneous rupture because there is a significant component of fat. It's a hemodynamic problem with a vibration that is worse, as Glagov pointed out many years ago, as the plaque is more stenotic. Plaques in the thoracic aorta are very important. We see lots of them with MRI leading to strokes. This is a plaque in general, very lipid-rich, that really fulfills the concept of vulnerable plaque if you tell vulnerable, meaning a significant content of fat and plaque rupture. And in the peripheral circulation, as I mentioned, most of these patients are diabetics, cigarette smokers, or hypercholesterolemic. There is no plaque rupture there. There is a clot on top of a very stenotic lesion. And we believe that these risk factors, diabetes, hypercholesterolemia, and cigarette smoking, can create a hypercoagulable state. And a plaque that by the Venturi effect is very stenotic but is pulled the endothelium out, that plaque that otherwise would not have a clot, with a hypercoagulable state, you have a clot. 1/3 of the coronary events belong to this category, and most of the events in claudication. And now we are going to discuss in some detail the last 2 points, which is what I consider we should be perhaps less ambitious in going to what we call the burden of disease. That is, where the disease from a systemic point of view, how significant it is, and can we score it. So let me talk about, from the diagnostic point of view, the so-called burden of atherothrombosis disease, which is called bad. I like the term, it's bad, it's very bad. Here we now go back to the pyramid and to the Framingham. The high-risk population is in yellow. This is for women, this is in men, and this is the age. Altogether, when you see people over age of 50, is about 25% of the population. I think Jean said a little bit higher. I believe it's 25-30% of the population. This is people at a high risk with a high risk score. And this is what we are doing. And this is a study we began some time ago that is now getting better and better as we move on. This is a high risk symptomatic patient. The layer I was mentioning, I'm going to be discussing. 4 technologies are being applied. First, calcium score. We are doing it because we do ultra-fast CT. Otherwise, the calcium score will be for the intermediate group. But we take advantage. The second issue is systemic MRA, injection of gadolinium in the vein and to see the systemic circulation. Third, ultra-fast CT, injection in the vein and to see the coronary arteries. And fourth, to look with MR, tissue characterization, the plaques that are identified in the systemic circulation with MRA or in the coronary circulation by CT. Now I'm going to present to you sensitivity, specificity, and the things that we need to know about these technologies as we are moving on and learning. Ultra-fast CT, before you inject anything, you can see calcium. What about calcium? Well, you have great experts in this room that we will talk later. We already said that add to the Framingham, but what about the sensitivity and specificity of calcium? Well, here it is. If you have 100 patients with coronary disease, 91 will have a calcium score that is abnormal. If you have 100 people without coronary disease, you are going to find that 36 have an abnormal calcium score. Therefore, the sensitivity is high. The specificity is not good at all. How do you improve on specificity? By quantifying the calcium score, which is what I presented to you before. More than 80, more than 100, then the specificity gets much better. And I think that to me is a summary of the present situation. We are now beginning to be interested in looking at the calcium score in the whole body and in the whole arterial system. And this is fascinating to find out a patient or an individual who is asymptomatic over age of 70. Look at this. About 85% have significant calcium somewhere. And in fact, with MR, they have disease, atherosclerotic disease. And I'm pointing this out to you because this is a systemic problem, that older you are, significant is more significant. Now we go to the second technology, MRA, which is basically to look with the computer. After you have done this, you can look at the different systemic arteries. The question that I like to answer today is there any future for MRA to the coronary arteries? And I like to give the answer, and the answer is no. I may be wrong, I may not be wrong. CT will much better. However, if you want to characterize the tissue in the coronary arteries, CT is not good, MRI is very good. So let's be sure that we distinguish between where the narrowings are and where let's characterize a lesion. From the point of view of MRA, I'm not entirely sure is going to make it in the coronary circulation with injection into the vein or without injection, but certainly in the systemic circulation will. Second, I said calcium score, MRA for the systemic circulation, now CT for the coronary circulation. Well, let's go into the data. And it's very interesting. If you pull JACC this week, you will be stunned by a paper that says the sensitivity of ultra-fast CT is 37%. Everybody's buying machines, and you read that paper and you begin to question, what in the world are we doing? Well, you have to read the paper very carefully, because the patients were not made bradycardic. The heart was beating at 80 per minute. You can see nothing. It's all blur. Second, they didn't use the 16 gauge that we use now today. And therefore, you really have to understand what you are doing before you buy a machine and how you apply it. I think this is very important. The sensitivity and specificity is pretty high for this particular technology, but I'd like to present to you two problems. The first problem is radiation, and that is ultra-fast CT carries a radiation that is higher than a coronary angiogram. The question is whether in the next few years it will be lower, and there is a lot of hope that it will, but that's one issue. The second issue is the calcification. You have a patient at a high risk, you have a high risk score, and the next question is this patient has coronary stenosis, and you are in trouble. Because the calcium overshadows the artery. You do not see anything there in terms of the narrowing. This is like when you go to catch an airplane and you carry your computer. They tell, take the computer out. Sure, you have to take it out. Otherwise, the people cannot see what is behind the computer. This is what happened with calcium. However, technology is advancing very rapidly. I see Dr. Rius here, Teresa, who has done fantastic work on the so-called angioscopy, and that we saw something in the coronary arteries that appeared to be like a plaque with a high content of fat. Today, the resolution is much better. Is 270 microns here that you can distinguish slice by slice. The most interesting thing is the molecular MR. Now we are able to see a single clot of 1.5 millimeters with MR by targeting the MR with the specific antibodies. For example, this is just 1.5 millimeter clot here. This is in the rabbit model. But also the fat. Look how beautiful. In other words, what I'm really seeing here is that molecular MR is going to provide incredible information, not only at the molecular level, but on the diagnostic level from the point of view of tissue characterization. And that's the way we are doing. However, even the plaques without injecting anything are becoming much more reliable in terms of sensitivity and specificity. Let me give you an example. We are now scanning the whole aorta. About a year ago, it took 24 hours, a couple of hours with the patient scanning and 24 hours of processing. Today, you can do everything in 1 hour, just a year, of how you process the images with MRI, simply working on the software. This is thanks to Dr. Zahi Fayyad. And this is when we do burden of disease quantification. I like to summarize what I said about the high-risk patient. What I said is that the disease is systemic. There are too many vulnerable or high-risk plaques. The composition of the plaque leading to an event is different depending on the region, not necessarily is a plaque rupture. And then I mentioned to you the combination of 4 technologies, ultra-fast with CT, MRA of the systemic circulation, ultra-fast of the coronaries, And then tissue characterization with MRI, where is the state of the art? And I'd like to finish, but what in the world is going on in the myocardium? Because the question is, the ischemia has an impact, and it's very important. And I'd like just to finish by making few comments. Because this technology is going to give an answer to something we do not have the answer. This is the assessment of the microcirculation. If you really look at the epicardial stenosis as here, could be vascular tone. In the microvasculature could be increasing tone, could be hibernation, could be stunning. We just reviewed the whole subject, and I'm not going to talk about non-viability or hyperenhancement or viability, how good MR is for this, but just to concentrate on ischemia. I think this is critical when we use all the stress testing today to figure out that PET is the best because it has the highest sensitivity and specificity. Echo stress test has very high specificity, but you miss many patients, low sensitivity, for example. MR is like PET on all the studies that have been reviewed, and I don't have to go into the detail in terms of perfusion, sensitivity, and specificity. Endobutamine MR is actually much better than echo stress testing. I'm saying this to you because at the moment that we do all these studies with MR, we can characterize the tissue and do this at the same time. And what is really happening here is that technologies are evolving in a unified fashion. And this is the summary of my presentation today, and this is what we are now doing in our laboratory. And that is, if you have a patient with an intermediate risk, I would say we need markers, and CRP in classification can be very helpful in putting this patient up in the scale or down in the scale. If you have a patient, as I define, with a high-risk profile, our goal is to have a single machine that will have CT and MR capabilities and will do everything in 1 hour. And basically, we are beginning to do this, but with two different machines. And that is, here you have CT for the coronaries. Here you have tissue characterization with MR. Here you have the adenosine stress perfusion with MR. This is really what you need in the high-risk patient. Then you have other things you can do for the patient with myocardial disease, hyperenhancement, and so forth, that is not what we are discussing today. So in summary, the way the field is evolving, in my own view, is that this intermediate risk patient population, which is about 40% of the population in this country over age of 50, maybe new markers, CRP and calcification today are really giving you a good hand. If you are in the patient that you are concerned whether it's developing disease or not, I think the technology that I presented to you today, not only in terms of the coronary arteries with CT as a roadmap and then follow with MR to look at the lesions, but also in the myocardium, these techniques are so powerful that I don't think we will have to send the patient here and there in the future. I think probably we'll be able to do it in a single place where all these technologies will be combined on a single machine. And this is basically how I see, at least from my point of view, the future on the high-risk patient. Thank you very much.